insulin is via a regulated mechanism involving neuronal, hormonal, and chemical mechanisms. You can get details from your physiology. The history of insulin was by accident. It was discovered by a physician known as Banting, being assisted by his assistant called Best. They are the ones who demonstrated that the hypoglycemic action of extracts of pancreas prepared after degeneration of the exocrine part due to litigation of the pancreatic duct could lower the glucose levels. So this discovery occurred in 1921 when Banting and Best extracted some molecules from the pancreas of a dog. And that is the beginning of the insulin story that we have today. 2 years after that, another physician discovered glucagon, which is an inhibitory hormone to counter the effect of insulin. And through that, the history of insulin and its antagonists started in earnest. It is reported that before the discovery of insulin, patients who had diabetes were being managed by starvation. This mode of management was advocated by none other than Frederick, Ellen, and Elliot Jocelyn, who are both American physicians. But then the discovery of insulin came on time through these two gentlemen, Banting and Best. One was a physician, the other one was an assistant. So today as we talk, we have various types of insulin, both synthetic and the original products, but their clinical use is based on the following factors: onset of action, peak duration of action, the entire length of duration of action, and where it is best injected or when it is best injected in a day. So based on that, we have several types of insulin. So draw a table containing 5 columns. The first column is for the insulin preparation. The second column is the onset of action. The third column is the peak action. The fourth column is the duration of action. And the last column is injection per day. So among the types of insulin, we have rapid-acting analogs, the Humalog and the Novarapids. In whichever form, the onset of action is within 10 to 20 minutes. They peak within 2 hours, between 1 and 2 hours. Their duration of action is between 3 to 5 hours, and they are best given immediately before meals or can be given together with the meals. Because of their quick onset of action, giving them together with the meal probably is the best. because they will start acting on the high levels of glucose immediately. Then we have the soluble insulin, 2 prototypes in the market, Actrapid and Humalin R. Their onset of action is between 30 and 60 minutes. The peak duration of action, is between 2 to 4 hours. And the duration of action lasts between 6 to 8 hours. These ones, because of their slow onset of action, they are given 30 minutes before the meal. Then you have the intermediate, what we call the lenta insulin, NPH. The onset of action is 1 to 2 hours. The peak action is between 5 to 7 hours. Their duration of action is between 13 to 18 hours. And because of that long duration of action, they are given once or twice a day. Then we have the biphasic mixture. The biphasic mixture. The biphasic mixture is a combination of Mixtard 30 and Humalin 70. So it is called 30/70. The onset of action is 30 minutes. The peak action is 2 to 8 hours. The duration of action is 14 to 16 hours. And they can be given twice a day or 12 hourly. Then we have the Lantas, what we call long-acting analog. Onset of action is 1 to 2 hours. They are peakless, and that is why they are long-acting. Duration of action can last up to 24 hours, and because of that, they are given only once a day. So these are the commonly encountered insulin preparations. Many preparations are still in clinical trials, and therefore the dynamics will change with the time. What needs to be understood is that the short-acting insulin, that is the BLT, they are very short in action, and therefore they require repeated injections. Otherwise, for the green line, which is the long-acting analogs, they take long duration of action and therefore should only be repeated less frequently because they take long in blood. When it comes to the preferred sites of administration, we have on the front, we have the chest, the abdominal muscles, and also the anterior thigh. At the back, we have the biceps and also the gluteal areas. These are the preferred sites for injection because those muscles are stable and may not require a lot of, they're not put into action a lot. But as mentioned in class, never give insulin injection to muscles which are going to be used immediately. So when insulin is administered, it should be understood that at the sites of injection, the abdomen is faster than arm in terms of absorption, and also the arm is faster than the thigh in terms of absorption. The absorption can be increased by exercise, by high temperatures, and when the areas that are absorbed are massaged. When the absorption again can be decreased by low temperatures, and individual variations also exist. And even within the same individual, there are up to 25% intra-individual variations. Insulin should be stored in temperatures between 4 and 8 degrees centigrade. And if not stored well, then the there is a reduced half-life. So when kept at that temperature, the human insulin or the humalin is stable up to 30 months from the time it is manufactured. But this is not the case with the other analogs. The other analogs can take 24 months. They should be stored in a very stable place, not at the bottom of the refrigerator, but somewhere midway, so that they are not affected by variations in temperature. Insulin must never be frozen, and once it is being used, if there's any crystalline structures, then that is indication that the insulin is probably not suitable for use. It is very easily damaged by heat, and once it is damaged, you'll see the cloudy suspensions with some granules, and even the color may change. So storage of insulin is quite important. So when given to patients should be advised on the following: chances of getting hypoglycemic attacks, chances of becoming sick, and those sick days should be taken into account, because any other concomitant disease will always affect the insulin action. Physical activity will always increase the absorption rate and the chances of getting hypoglycemic spells. There should be self-monitoring, and diet is still not, dietary management should still be carried alongside. So I'll not go much into the non-insulin injectables, but we know there's glucagon and there's also pramlidine. I want to touch slightly on the targets. When it comes to treatment targets, we have the index, situation, and also the goal. So the use of insulin is determined a lot by the presence of glucosylated HB. HbA1c should be targeted at 6.5. The fasting levels of these patients should be between 4 to 7.2, and postprandial should preferably be around 8.3. The lipids, low density lipoproteins should be 2.6. High density lipoproteins should be 1.1, and triglycerides should be 1.7. These are the targets for treatment. How does serum levels of glucose vary with glucosylated HB? When the HbA1c is 6, glucose levels sub 7.5. When it is 7 is 9.5. When it is 8 is 11.5. So increases by 2. When it's 9, 13.5. When 10 is 15.5. When HbA1c is 11, then glucose level is 17.5. And when it is 12, it is 19.5. So the higher the HbA1c, the higher the HbA1c, the higher the glucose levels. So the rest may be just how to use insulin in different situations. And those ones can be discussed in clinical lessons other than pharmacology. So that's just a recap of insulin. From there, we move straight away to oral glucose lowering agents. A1C levels. They also reduce glucose variability throughout the day. They raise post-meal levels of GLP-1 type of hormones. These are glucose, what you call the glucose-like proteins. There are a series of hormones in the body, and this series of hormones help in delaying the digestion and decrease the appetite. So through delay of digestion and decreasing the decrease of appetite, the glucose levels come down. However, they don't affect fasting insulin and insulin triglyceride concentrations. There are 3 prototypes: acarbose, miglytol, and voglibose. Generally, these drugs they are competitively inhibited by pseudo carbohydrates, which end up delaying the digestion of complex carbohydrates in the upper small bowels. Subsequently, there is retardation of the absorption of glucose, and there is the dulling or retarding of postprandial hypoglycemia. So they plateau the absorption of glucose, and because of that, the glucose levels are moderated. When it comes to dosing, acarbose is given at 100 milligrams 8 hourly. Voglibose is given a dose of 0.2 milligrams 8 hourly, and miglytol is given a dose of 50 milligrams 8 hourly. The side effects: the side effects of these drugs are mainly dose related. So when the doses are regulated, then you'll not see much of it. So the GIT effects like flatulence and diarrhea have been reported. And that is why these drugs are supposed to be started on very low dose, and the increment should be very gradual and in a step ladder. The toxicity: much of toxicity is reported when given together with sulfonylureas, and similar combination with insulin can also bring about hypoglycemia. So the hypoglycemia can be so life-threatening to the point that patients who are put on these drugs must always have monosaccharides or glucose tablets in order to reverse any hypoglycemic episodes which may occur. So as a word of caution, patients who are put on any of these 2 drugs, let them be advised to carry monosaccharide glucose, which can be used for emergency reversal. Otherwise, that is the short story about oral glucose lowering agents. Look for details and fill in the gaps. Unless there's a very urgent question, I beg to stop there because I have another lesson at 7. So any question up to that point? I can see some people are still struggling to come in when we are almost finishing. So apart from the glucose lowering agents, which are injectable and orals, Please read about corticosteroids. That will be our next lesson. And with those many remarks, I beg to stop and end there in preparation for the next class.